So obviously I come from a different world than most of you are practicing in, right? So I've kind of made some assumptions as I put together my presentation, so please correct me if anything is completely inappropriate, and we can redirect things on the fly. I'm very comfortable with that. As far as questions, feel free to ask them during, when we're on the topic, all right? Don't feel that you need to wait to the end. It's great they put me right before lunch because I tend to keep talking, so this way no one else is being held up by me. All right. So I think we mentioned this in the introduction that I've been at the Toronto Vet Emerge for about 13 years now, and now it's more than 20 years in emergency referral medicine for me. I am not a specialist in any way, shape, or form. Linda asked me, for my credentials. It's like, okay, I'm a DVM. Full stop. All right, that's me. All right, so nothing that. My interests are probably stressors for most people. So I'm interested in surgery that's not going well. I'm interested in really bad trauma and dogs that are trained to bite people. So those are the things that I'm interested in and have a big focus on. As I was putting this together, because of all the training I do with police dog handlers, most of my pictures are dogs. So I tried to put some cat pictures in because I do like cats, but I just found I didn't have a lot of cat pictures. So our outline, we want to talk about what is triage, so how do we classify it, but I think more importantly, approach to emergency patients, because that's an area that I'm very comfortable with, and again, something that falls outside the comfort zone of a number of primary care veterinarians in general, not even if we further specialize down to shelter medicine. So try and give us some comfort level with approaching an ER patient. Going along those lines, some emergency interventions. So there are some things that can be done, even if ultimately you're going to be referring that patient somewhere else. There are a number of things that you can do that are pretty easy to learn once you get over that discomfort with them, that can make a huge difference on whether or not that patient actually gets to us. Those are probably the most sad when veterinarians that are referring are uncomfortable doing a procedure, so they send them and then they die on the way. That's pretty horrible for everybody, including us receiving them at the other end. And lastly, some things that can make referral go more smoothly. Obviously, I'm at the end of the phone taking referrals all the time, and there are some things that can make that process go easier for us as well as better for your patients. Okay. So triage classifications, there's lots of different ways of breaking down triage, right? And it really comes down to urgency of care and classifying them based on that. Here is more of a hospital base. So this is appropriate for us, right? How quickly do these patients need to be seen? This is us with a waiting room full of patients, and we're trying to decide who to see first, which is maybe not realistic or applicable to your situation. This is kind of what I thought would maybe be a more applicable triage classification, right? That you're going to have some animals that are either surrendered or already in the shelter situation or being brought in by strays, that they're stable. They don't need any type of urgent intervention. You're going to have ones that are stable, that could stay in the shelter overnight, so they have something going wrong, but they don't need any monitoring. I guess from my information, how many shelters in the group would have some type of technician overnight or any type of animal care attendant overnight? Is anyone? So very few, right? Okay, so we're really looking at, do they need any intervention? Can they stay in hospital unobserved? Or are we looking at, we should be referring these patients because they are going to need overnight monitoring? Are we referring these patients but we should be doing something before we send them? Or that last category, are these animals that really we should be strongly considering euthanasia because of what the prognosis is for that patient? Some animals that I thought would be reasonable to leave in the shelter unattended. And for me, these are patients that I would be very comfortable managing as outpatients, understanding that the client has little to no training and is probably going to go to bed and not observe their pet overnight, right? So mild gastrointestinal upsets, unblocked cats, so cats that were blocked but now are unblocked and are cardiovascularly stable. I think those are reasonable. Lamenesses without fractures, or even some non-displaced fractures, skin disease, and some degree of upper respiratory disease. Things that I would consider things that should be referred. So obviously breathing difficulty, severe metabolic disturbances, derangement, severe dehydration. And the reason I put a question mark on seizures is that in a lot of cases I am managing seizure patients as outpatients. So the animal that's had one observed seizure, they're not necessarily going to progress to a cluster. A cluster is a very different situation. So I think it'll come down to an individual assessment of that patient and risk, whether you decide that that's someone that needs to be referred for monitoring, or whether you're comfortable leaving them unattended. There are not a lot of cases where I say there's no hope. All right, I see a lot of really bad things that end up going home. Okay, bicavitary effusion is not one of those things that goes home. So I'd say yes, referral. We can work things up further. We can get a diagnosis, but the chances of that animal doing well are very small. Saddle thrombus. Has anyone ever treated a saddle thrombus successfully? No. All right. So I think that's not. We're not looking at referral, making a decision to stop at that point for that animal in that animal's best interest. Sometimes its cost of care is unacceptable. Right. I know all the shelters have different. The amount of funding is going to be very different from shelter to shelter. How you use those financial resources, that's a really hard decision. So part of the decision about euthanasia may be that this animal may be fixable, but maybe the cost of that care is unacceptable. And the last category for me is best case scenario is unacceptable. And I run through this a lot with clients, right? To help them make an informed decision about stopping and moving forward. I outline for them, if everything goes well from this point forward, this is what it's going to cost, and this is where we're going to be at the end. So that they can make a decision, well, if the best case scenario is unacceptable, then we're stopping, right? And if anywhere along the line that we're reviewing what our best case outcome is, we may be making a decision to stop. One of the things Linda asked me to speak to is how do we prepare staff, right? So how do we prepare staff? And some of that might be providing, our reception team. Like for our case, it's our reception team. I'm not sure how it's going to be set up for you. With some examples or conditions or clinical signs that immediately set alarm bells for them. So they're telling clients to hurry in right away, right? Or also giving them information about accepting or diverting. So if we give them a list of clinical signs that they can, if they're taking calls from members of the public that want to surrender an animal, or if they're the only one in the shelter and they're assessing those animals, they can use that as a guideline about do they need to be contacting the veterinarian, is this something that's okay to wait, or is this something that we should be looking at diverting them to a different facility. I think that's going to be different depending on what you have. I know even between the groups I deal with, Toronto Animal Services and Humane Society is very different in what their capacity is for providing in-shelter care. Right? So that decision and that list is going to be very different based on your resources, whether those are human resources, facility resources, or financial resources. So this is obviously the part that I am the most comfortable with. So how do we approach the emergency patient? Right? So we're triaging them. So in our hospital, we have that, that first slide I showed of triage is how long do they need to wait, how quickly they need to be seen. Right? I think we get a lot from the signal mitten history. We're going to want to do a focused initial assessment to try and determine how stable they are, and that's making some decision about what intermediate interventions may need to happen, and then coming back and then redoing a physical exam, and then following up with some simple diagnostics. So signal mitten history. So an example for me about how important signal mitten history can be. If I have an old and golden retriever that suddenly collapsed, my list of differentials immediately starts as pretty small, right? It's meningiosarcoma or it's pericardial effusion, and then maybe it's something else, okay? So it does give you a starting point, but I also think it's important to avoid tunnel vision, right? Maybe the old golden retriever got into their pot, and now he can't get up, right? So I think coming up with a list of differentials from your signal and history is very, very appropriate and helpful, but we still want to avoid those blinders and not thinking it can be anything else. Our focus of physical exam is to determine how stable that patient is. Right. Level of alertness is very important. That's probably the most important vital that we can assess. Right? A bright and alert animal is much less likely to have anything immediately life-threatening. As we go down levels of consciousness, that chance becomes greater and greater. We want to evaluate respiratory effort, as well as mucous membrane and mucous membrane color. So that's kind of my short list. We have that's followed up with abdominal palpation, feeling for pulses, listing the heart and lungs, and getting temperatures. So how do we categorize our level of mentation? I know you can go and you can find like modified coma scores for dogs and cats. I don't find them very useful. Right? I'm dealing with, are we bright and alert? Are we restless? Are we anxious? Or are we dull or depressed, progressing to stuporous, to comatose? Are we coming and seizing? Seizures versus tremors. I think I see fewer tremor emergencies. I don't know if there's a good reason for that. Maybe a decreased use of slug bait. It used to be seen that was a fairly common poisoning that we would see. Slug bait would cause pretty dramatic tremors. The other thing is bread mold causing tremors, and they can be challenging to differentiate seizures and tremors, with the biggest difference being that loss of consciousness or loss of awareness. Right? They are managed very differently. Right? The drugs that you're going to use to control seizures are not going to be very effective for tremors, so differentiating them can be helpful. In that situation, we'd want to be establishing IV access if we have an actively seizing patient. Right? So as I mentioned, a one-off seizure, I don't rush to get IV access because we have no indication that they're going to progress to a cluster. But an animal presenting in status needs immediate intervention, and that's establishing an IV access, checking blood sugar to determine if this is a hypoglycemic seizure, and then using different drugs to control those seizures, with obviously the immediate go-to being diazepam, but for longer control, phenobarb or levetiracetam. And this might be a situation then that you are referring this patient. So if they arrived in status or arrived having part of a cluster, I would say that's not a patient that you'd want to leave unmonitored overnight. Getting a loading dose of phenobarb, 2 or even 4 milligrams per kilogram, and levetiracetam. Does everyone have availability of oral Keppra? Or would you have availability of oral Keppra in your practice? So a diazepam CRI used to be my go-to for managing cluster patients or for managing status. But as long as animals are swallowing, I find that giving them Keppra at a loading dose of 60 milligrams a kilogram is an excellent way to break clusters. And you don't have this nightmare of the huge cluster seizure Rottweiler coming off a diazepam CRI, because that's absolutely horrible. Right? So it's a cost-effective way because you're not managing a CRI. Definitely logistically it's easier, and the recovery as they're coming off those drugs are better. So when we're assessing breathing, what we're concerned about is dyspnea. So is there anything we need to do to immediately address breathing distress? The majority of animals that come in to us that are having any signs or any suggestion that there might be breathing distress, we get oxygen in front of their face and we get sedation on board. Does anyone actually use these masks? Does anyone have? I've seen them and I found pictures online. I didn't credit the pictures like some of the other speakers did. I'm probably breaching all sorts of copyright. We don't have these. We have just the anesthetic style. We take the rubber off of them so we can kind of direct a cone of oxygen towards their face. The nasal cannulas work well in dogs, so the human nasal prongs can work quite well. Or the simplest really is holding an oxygen line in front of their face. And that may be the simplest way to provide some supplemental oxygen. Also, animals that are having breathing distress, a lot of them don't tolerate anything in front of their face. You can't explain to them that this is helpful. So instead of generating more anxiety by trying to hold them still and getting a mask over their face, it's holding something just anywhere near them The cone can help just kind of direct that flow of oxygen a little bit more towards them, and sometimes less is more, so keeping that oxygen flow rate turned down so that they're not trying to move away from it and actually causing them more anxiety, increasing their oxygen requirements. So these are the things that I see as most likely to cause airway obstruction. Because when we talk about breathing distress, it's airway, so are they getting air into their lungs? And then it is respiratory, so is there a problem with their lungs or their pleural space? And this is kind of my short list of the most common. Fortunately, we don't have sound on this. Can you give me sound?
I think I can give you sound.
Picture and sound? Okay. So this is a pretty classic example of airway obstruction, right? You know, I couldn't tell if this dog came into the hospital, I couldn't tell you if this was laryngeal paralysis, which in an old lab, there's a good chance that that's what it is. Or does this dog have a mass, or does it have some toy obstructing its airway? And so these are all possibilities. So we have that stridor, we have the cyanosis, we have this increase in breathing effort. Regardless of underlying cause, this dog would benefit from some sedation, with butorphanol probably being my primary go-to. And I don't start at 0.1 or 0.2, they start at 0.4, right? And they get some flow by oxygen, right? And then we can, so that's our immediate intervention, and then we can start teasing apart how are we going to go from there, okay? So these two things that have in common, these are both things that I've dealt with as airway obstructions. All right, chuck it balls. It was horrible. So could you imagine being this pet owner? It was a German Shepherd. He was playing with chuck it ball. The dog, and it obstructed in his larynx. All right. So the dog passed out. And when he passed out, it would relax enough that he could breathe past the ball and he'd regain consciousness. So he went through about 8 cycles of choking out and regaining consciousness by the time he got to the hospital. So terrifying for that owner, all right? I use this picture because it's incredible that I found a picture of a ginger and a German Shepherd. I think a Heimlich in a dog is a completely useless thing. You think Heimlich in people, you're driving force up against the diaphragm to have them expel an object. There is no pressure up against the diaphragm in what you're doing here, but you can find these kind of pictures online and they're probably copyrighted too. But I decided to claim ginger prerogative and use that picture. Right. Heimlich and lateral, maybe, right? So if you had an object stuck, potentially compressing the chest of that patient could dislodge that object. I think you're going to be more successful in a dog than in a cat because of that degree of chest compliance. Okay. But that would be something I would try. I've never had to do it. No, has everyone seen this video? Yeah. This is a fantastic video. Right? Because ball obstruction is horrible and fairly common. Right. So it's like dogs are almost designed to have a ball stuck there with that space over the base of their tongue. Right? So you know when you've gone to intubate a dog, that space over the base of their tongue right in front of their larynx, it's perfectly shaped for a ball to be obstructed there, right? Incredibly challenging to get them out. You know, that chuck it ball, the dog I described, the story with the chuck it ball. We happened to have one surgical pack that I knew had these long caramels that were rat tooth. They were fantastic, right? But chuck it ball is kind of squishy. Lacrosse balls, way less squishy. Really impossible to grab and pull out, but this technique of pushing behind, right? So this is something that I learned from that video, and now I haven't had an opportunity to use it on a patient, but that's definitely something that would make things easier for sure. So what are our options? If we do have a dog that has an airway obstruction, we can't remove that object. We're looking at either endotracheal intubation, if we can get around, if it's a mass, if we can get around it and provide an airway. If that's that old dog with laryngeal paralysis, if we can get past that larynx and establish an airway. Or we're looking at a surgical tracheostomy. Right, so obviously everyone in the room has intubated a dog. Probably fewer have had a situation where they've had to do a tracheostomy. I think the surgical skills required to do a tracheostomy are pretty minimal. Probably less than spays and neuters. Right? But it's the stress during the procedure, right? We have an animal that's not breathing well. If we're staying on midline, there's not a lot of bleeding associated with a tracheostomy. But we want to identify that trachea in the middle, somewhere between the thoracic inlet and the larynx. Right? We want to stabilize that. Depending on the size of the patient, we're either making a transverse or a longitudinal incision. Right? But right there, as soon as we got to that point, that dog's breathing. You don't need any fancy equipment for this. This is a scalpel blade, a pair of hemostats, and an endotracheal tube, and we've established it. Because you could imagine that a dog that has some type of airway obstruction, sending them on a drive down to see me, that's an example of one of those patients that may not arrive. Yeah?
Let's just say like we're at a general practice and like the dog couldn't breathe, had some sort of obstruction,
Yep.
and we did this.
Yep.
Can you send the dog with just the ET tube without it being like connected to the anesthetic machine? And
Definitely.
It's still okay to breathe fine?
Yeah, yeah, and we'd want sedation. So in that situation, we'd probably have IV access. The person accompanying the dog or transporting the dog would need to be keeping that dog sedated for the trip, right? But if we're dealing with airway obstruction, if there's nothing wrong with that dog's respiratory system from that point down, there's no reason they can't breathe through that tube, right? Same if the endotracheal intubation, as long as we're bypassing the obstruction, we can keep them sedated so they're tolerating that tube. There's no reason they can't be transported that way. All right, and I would say you wouldn't even really need flow by oxygen as long as we're keeping them sedated and calm during that transport. Right? And we do have patients, or we manage patients that they have permanent tracheostomy, so they go home without any tubes. It's more of an established airway. There are lots of complications that can be associated with that, but dogs can live with a surgical airway.
I have a question.
Yeah.
Are you inflating the cuff, and what size tube would you choose?
Definitely. So definitely inflating the cuff, because depending on what's going on up here, there may be fluid draining down into that. We may have blood from our incision draining into that. Size of tube, it would be the biggest that would fit for that patient. I don't know that we can give you specifics on that, but definitely inflating the cuff. Yeah. Smaller patients, you do have to be more concerned about intubating into one bronchus if you do push that tube down in too far. So that's our airway. So moving down from the airway, well, we can have lung and pleural space issues, right? So that's pneumothorax, pleural fusion, right, as our pleural space issues. We can have pulmonary edema and pulmonary contusions, pneumonia and asthma. And those are probably the most common causes of breathing distress. So we're trying to differentiate, the video is really trying to differentiate between panting and breathing distress, and admittedly it can be challenging if you don't have any history. Right? If you were told the dog was hit by a car and he's having some increased breathing effort, or it's a balcony cat, well, I'm thinking immediately you're starting to think about pneumothorax. Well, you may not always be in a situation where you're getting any type of history in a surrender or a stray. But we're looking for that increased abdominal effort. So not necessarily the rate of respiration, but do we have an increased effort associated with that? The stridor, do we have any abnormal sounds? Here maybe a little more subtle. So this, just the head and neck extended, a little bit of a worried facial expression. Some increased effort to the breathing rather than just increased rate. Supplemental oxygen being provided to the armpit. And then moving back up to the face. So of those of those first two videos, the first one actually did not have any pulmonary disease, despite the breathing distress. That's a dog that had been exposed to a toxin and had paralysis of its respiratory muscles, so it was all abdominal breathing. But I think it highlights what increased breathing effort looked like. That second video was a dog that was hit by a car and had a pneumothorax, but very similar in terms of the head and neck extension, the increased breathing effort, and that's really what you're watching for, because if those are going on, it might be a situation where you can provide an intervention before referral that's going to increase that animal's chances of doing well. Right? Things that can look like increased breathing effort, but aren't necessarily, again, due to respiratory disease, is internal bleeding. So a marked decrease in oxygen carrying capacity because we have blood loss is going to look very similar as that animal is trying to get more oxygen into their body. So thoracocentesis. How many people would say, show of hands, are comfortable tapping chests? Right, so some. Okay. I find that if I have a patient that is on the triage table and they have a history that I think they're going to have a pneumothorax, I'm pretty quick to try to tap it. Right? I'm not very good with a fast ultrasound looking for pneumothorax. So some people say you can use that as a tool to be very confident. I'm not confident with it. X-rays are fantastic, but taking an animal with breathing distress and putting them on the X-ray table and holding them down may increase the chances of that animal decompensating. So I'm pretty quick to stick a needle in a chest. And our chances of doing harm are pretty small. Like, I don't know how many thousands of chests I've stuck needles in, and I can count on one hand the number that have had significant complications. But it's a fear thing because it's not something you're doing every day. What intercostal space do you do a chest tap at? Anyone? 7th or 8th is kind of our standard. Well, we can count backwards from, our 12th intercostal space, which is the back one, so we can count from back to forward. A really fast way of doing this, though, is if you put one hand at the end of the ribs and one hand behind their shoulder blades, and you find the spot in the center with your thumbs, that's your 7th or 8th intercostal space. Right? So if you have patients that are moving around, you have patients that are obese, that you can barely feel their ribs, this is a pretty easy way of getting your landmark. So here we are behind the ribs, at the end of the ribs, behind the shoulder blade, finding that spot in the middle. After I made this video, I really should have had the cap off of that catheter. There's no benefit of having that plug. It's habit to put my thumb over it. I don't know that it really makes a difference because we're then going to hook it up and suck air out. And I specifically say air because if we're doing this in lateral, it's because we're concerned that there's air. Right? Because air is going to rise up to the highest point. So we're using that 7th or 8th intercostal space. We're advancing that catheter into the chest because once that catheter is there and the stylet's removed, we're not worried about causing any damage to the lung tissue as we evacuate the air and then the lung comes back up against what we have in the chest. Cats I still very often use butterfly catheters. You just have to be aware as you're evacuating the chest that now the lungs are going to have the potential to come in contact with that needle. Yeah.
Have you used those Myla instead of the Stockhawk? Those Myla two-way valve thing?
I've seen them.
They're awesome.
They're awesome and they're super expensive. And I think, sorry?
Have you ever used them?
Yeah. So we haven't gone to those. I've had the opportunity to use them once or twice. They definitely make things faster. For sure, and I think the reason we don't have them in hospital is economics. Right?
Just when I'm stressed, I can't do the two-way stop.
Yeah.
My brain won't do it.
Yeah, and the last time I ran to the hospital for whatever reason got 4-way stopcocks, and I'm like, I don't know what to do. I was having to look and see which way does it actually say off. Yeah, it was horrible because then it has 2 arrows and you had to turn it. Oh, don't buy those. Yeah, so I've only used those once. The other catheters we've used, Mila makes a catheter that's pre-fenestrated. It's more for removing fluid than air. But I find anything bigger than a 14 gauge, you'll have to do some type of cut down, or the catheter likes to bunch up on the needle. So it's a great concept. It's a 12 gauge that's pre-fenestrated, so you can get fluid. It doesn't plug as easily, but I find you do have to do a cut down, which slows down your procedure a bit. Right. So here's pleural effusion. So our other pleural space disease that we may have to tap. So now we're sitting in sternal because we want the fluid. Gravity is going to carry that fluid down towards the table. So we're using the same landmark, that 7 3/8 intercostal space, but as we introduce that catheter into the chest, we want it directed ventrally so that we can then remove that fluid.
How long is that catheter?
I think they're usually 3 inches. Yeah, and I don't always sink them all the way to the hub. Obviously, if we have a smaller patient, we may only have part of it in. Yeah.
Why don't you just like poke more ventrally?
So the end of the catheter ends up ventrally.
Yeah.
Right. So I'm going in mid-chest and just directing it down. If I go in very ventrally, have a lot of that catheter out, it's just more likely to pull out if the patient is moving around. So moving on from respiratory, so we've done a level of alertness, we've dealt with airway issues, we've dealt with breathing issues, or assessed those and moved on. Now it's circulatory. And we're trying to make a decision. Do we have, is this patient having difficulty maintaining perfusion to tissue? So that's shock. So we're evaluating our circulation. Blood loss, we know that blood volume is 7% of body weight. So a 30-kilo dog, we have about 7 liters, and they can lose a whole lot of blood before they start to show any clinical signs. It's not until they really lose about half of their blood volume that they get into a lot of trouble. And I would say if we're talking about intervention, something that you feel that you need to intervene before referring that patient, it's probably that decompensatory stage that we need to be actively providing volume to increase their safety. When we're using fluids for shock or hypovolemia, very different than we're using fluids for dehydration. So we want to give a rapid infusion of fluids to expand the vascular volume, as opposed to a more gradual infusion of fluids so that it redistributes into tissues. We're wanting to evaluate heart rate. We're wanting to evaluate capillary refill time, and the other thing we can use as a guide to help us evaluate perfusion is our dorsal pedal pulses. We want to make sure that we have a fluid resuscitation plan right before we're starting. To start this, we're going to need IV access, and we're going to need to decide what fluid type we're going to administer. After we decide on this fluid plan, or part of that fluid plan is we're going to give bolus fluids, and we're going to decide what our endpoint is. Should probably have these in another order. So when we're evaluating, that chart said we have an increasing heart rate. So if we have a trauma patient, we have either suspicion or we've confirmed that they have blood loss, right? We're using heart rate as a guide, so an elevated heart rate that they're starting to compensate. We start to have a prolonged capillary refill time. Right? And dorsal pedal pulses are something that I use very commonly. Does anyone, say a show of hands, or who is comfortable finding dorsal pedal pulses, or even knows what I'm talking about? Right. So dorsal pedal pulses. So I apologize. I thought I have a picture of this, and maybe I've just got my slides out of order. Dorsal pedal pulses are inside, towards the medial aspect, distal to the hock, is where you have your dorsal pedal artery. And the nice thing about dorsal pedal pulses is we know that we lose those out of a mean, or when the blood pressures are around a mean of 60 or 70. And dogs and cats that have lost their dorsal pedal pulses are patients that would really benefit from some volume resuscitation. So if you're using it as a guideline of, should I just send this patient? Is this patient okay just to send, or should I be doing something at the shelter first? Loss of dorsal pedal pulses is a good thing to use as a guideline. Okay. So when we're doing fluid resuscitation, when I was in vet school, which I outed myself in the bio there, is quite a while ago, we were taught shock rate fluids, 90 mils per kilo per hour, right? Great. Well, how long do we give that for, and what are the complications of giving that for too long? So to balance the complications of overzealous fluid administration with the benefit of expanding volume, we want to give a set volume and then reassess. You know, I'm typically using in the range of 10 to 20 mils per kilo, depending on how bad I think things are. Right? Cats, I tend to be a little more conservative and give 10 mil per kilo boluses and reassess a little more frequently because they tend to suffer the complications of fluid administration more than dogs. So we give a fluid bolus, right? So we give that fluid rapidly over about 15 minutes. Then we reassess. Do we have return of dorsal pedals? Has their mentation improved? Has their heart rate come down? And then we make a decision, are we going to repeat that? Hypertonic saline. Hypertonic saline can be great for multi-trauma patients. You know, I'm using it commonly when I have head trauma because the hyperosmolality of that solution draws some of that cerebral edema away, as well as providing volume expansion. We're using smaller volumes than if we're using crystalloids, isotonic crystalloids. The other part of our assessment is temperature. And this is another area where early intervention can make a big difference in outcome, right? So if you have a patient that is presented to you and you're worried about heat stroke, just sending that patient before cooling them down is not ideal, right? We want to start cooling that patient aggressively. So there's no such thing as cooling them too quickly, right? That used to be thought that if you cool them too quickly, you could cause more complications. I think that's been disproven in human medicine, and we're probably just catching up with that as a theory. A lot of dogs that have heat injury, we're managing not just their temperature, right? If you think of the dogs that overheat, that French bulldog that someone decided the nice day in May they were going to take it rollerblading, kind of situation that I see. So we're trying to manage airway at the same time as maybe we're managing shock with some fluid boluses and we're cooling them down, and this is all happening at the same time. With the most common way that we're cooling those patients is simply wetting them down and having a fan on them, right? Anything fancier than that, I have not found makes more of a difference, right? So sure, I've heard spraying alcohol on their foot pads. Sure, it's a pretty small surface area, so the evaporation may cause some cooling, great. Wrapping your IV line around an ice block, sure, if you're giving those fluids quickly, I don't know how much it's actually being cooled, right? But the fluids are already probably at 20 degrees room temperature, which is a lot lower than their 40 that we're worried about, right? Ice packs in the armpit and groin, sure, but I don't think anything beats getting those animals wet and getting a fan on them. We do want to trend body temperature, so we can't cool them too quickly, but we can cool them too far. So when we're hitting approximately 39, we want to stop, knowing that their body temperature is going to come down, continue to come down beyond that. So that was our focused physical exam. We're going to go through some things quickly. We're going to decide, do we have to do any immediate interventions to stabilize that patient? And then we can come back and we can do a more thorough physical exam to answer some of those other questions about what is our best case scenario, right? What ultimately is this animal going to need to make them a well animal, and then to help you make that decision between referral and euthanasia. There are some emergency diagnostics. Quats are quick assessment tests, all right? So you don't need to do a lot to get quite a bit of information. Right? I very rarely am running comprehensive blood testing before having a conversation with a client about prognosis. I don't need that. I often need PCD total solids. It's great if I can have a creatinine and a blood glucose and electrolytes. If I can have that, That gives you a whole lot of information to come to a diagnosis and to make some decisions about prognosis. Right? Our other diagnostic, blood pressure measurement. We started with fingers. Fingers are the best thing we can use to try and get some sense of where we're at with blood pressure by getting pulses. SpO2, sure. During anesthesia, I find it's a helpful tool. I don't find it that helpful a tool on a triage table for a couple of reasons. One is, where do we put it on an animal that we can reliably get a reading? Right? Sometimes it generates either panic or a false sense of security. Right? So it says 88, but the animal doesn't look like they're having breathing distress. So how much do we chase that, or what do we do about that? And conversely, sometimes I think it gives us falsely elevated numbers. Saw a great video. It was my wife had a presentation. She had an SpO2. It was clipped to a fleece, and it was reading 99. It's fantastic, right? To give you an idea of that. So I put it on this list because a lot of people do use it as part of an emergency. If the animal to me looks like they're having breathing difficulty, I give them the benefit of the doubt, and I put oxygen in front of their face until I've proven otherwise. I don't put a lot of stock in an SpO2 monitor. I mentioned radiographs in the context of pneumothorax, and that I tap them preferentially over doing x-rays, but survey x-rays can be very, very helpful. Our radiologist loves it when I take catagramms, or only one view, but the reality is sometimes, you need that initial information. You're treating them truly as survey to get a better sense of what's going on, knowing that you can always circle back and get more appropriate radiographs if that's necessary. Right? Who has access to an ultrasound as part of their practice? Probably about half. It's very interesting for me in the emergency medicine setting. I would rather give up my stethoscope than the ultrasound machine. I'm at that point because I find that I can get a lot of information from that very quickly. So our summary of our approach to the emergency patient is we want, if possible, getting a history and signalment, knowing that's not always possible with the patients that you're dealing with. We want to be doing a focused physical exam, some of those vitals to know, do we have to do any emergency interventions? We're following that up with a more thorough physical exam and potentially some diagnostics at the end to help us establish a treatment plan. So that brings us to referral. I think it's very, very important that you are calling before sending. And we don't always get this from the referring veterinarians that we have coming to our hospital. Right? One, just giving us a heads up that something on the way can be really helpful, right? Particularly if it's something bad. Your example, can you transport them with a tube in? If something was showing up with a tube in, I'd really like to know ahead of time, right? I can deal with it, and I probably won't panic, but I would like to know, so just the heads up. A thing really that we've been dealing with just in the last couple of years is capacity limits, right? I'm sure you're all familiar with how stressed the veterinary system is. Emergency, it's dramatic. Like, I used to be disappointed when we had wait times of more than 2 hours, and now we're telling people to come back the next day. And the idea that we would say no to a transfer or referral is unheard of, and now it's routine. Right, so it is important that you're calling ahead to make sure that the place that you are sending them has the capacity to deal with that patient, whether that's staffing capacity, whether that's things like blood products. Right? Also, if you are sending clients, so if you are sending owned animals to us, that we can give you some sense of what to expect for wait times. When we have shelter animals coming in from Humane Society or Animal Services, typically they are being dropped off and we'll accommodate and fit them in where we can. But if they are coming in with owners, then those owners need to have some sense of what to expect. Also, we talked about limited financial resources depending on the situation with your individual shelter. So calling ahead will allow us to give you some idea of what costs might be incurred. So you can either pass that along to a client-owned animal, or you can make an informed decision about, is the cost of care, expected cost of care, going to be prohibitive and be a reason to consider euthanasia rather than referral. The other thing helpful about calling ahead is being able to tell whether you had to do any interventions. And also the follow-up plan, right? So who are we talking to the next day? Who is the go-to? Because obviously that can be a very dynamic situation in terms of the veterinarian that saw the animal referred them to the hospital may not be the veterinarian that's going to be the contact overnight or the next day. So it's important to be able to relay that follow-up plan so that it's clear, right? And medical records. I want you to call and I want you to tell me all the details, and then I really, really want you to write them down. Because that could be the 4th or 5th phone call I've taken in the last 15 minutes, and I'm going to forget a lot of it. So sending those medical records in a timely fashion is very, very helpful. The number of referring clinics that tell us they're too busy to send us the records, it makes my blood boil. It's like, I have 15 patients and a waiting room full of people that have been waiting 8 hours, and you're too busy to send me your medical records. Okay. That's great. Send them when you can. Don't worry about it. We're fine. I went through that faster than I thought I would. But I'm definitely happy to take any questions either on that material or anything about emergency or referral.